Okay, I'm going to start now. So, welcome everyone to the first Mental Health and Wellbeing SIG webinar of 2026. Thank you everyone for being here. It's so lovely to see such a great turnout for what is set to be an insightful webinar with three fantastic speakers, speaking to the design, development and implementation of community-based physical activity programmes for mental health. I'll just start with introducing myself. My name is Victoria and I am the webinar lead for the Mental Health and Wellbeing SIG, and I'll be leading the webinar and helping to ensure that it runs as efficient as possible. Before we get started, I'll also introduce each of our speakers and run through some housekeeping for the webinar. But first, I'll let Masha introduce herself as well, as she's kindly here to also offer support.
Hello everyone, I'm Dr. Masha Remskar. I am a postdoc out at Arizona State University, and I'm co-chair of the Mental Health and Mental Health and Wellbeing SIG in ISBNPA. Thank you.
Great, thank you, Masha. So now to introduce our speakers who have kindly given their time to present on three very interesting projects. First of all, we will hear from Professor Joseph Firth. Joseph Firth is a Professor of Psychology and Mental Health at the University of Manchester, internationally recognised as one of the most highly cited scientists in lifestyle interventions and digital technologies in mental health care contexts. He was awarded the CERN Laureate in Social Sciences in 2022 and named Research.com's #1 Rising Star in 2023. Having published over 300 peer-reviewed publications, including works in the BMJ, the NEJM, Lancet Psychiatry, and the World Psychiatry, his current research leverages digital technologies and lifestyle medicine to improve outcomes for people with mental illness, specifically in youth mental health care. Dr. Firth has had leading roles in major policy guideline pieces, including chairing the Lancet Commission on Physical Health in Mental Illness, acting as expert advisor for the World Health Organization's physical activity guidelines and the European Psychiatric Association's guidelines on exercise and lifestyle interventions in mental health care. Next, we will hear from Dr. Gareth Jones. Dr. Jones is a research fellow in the Physical Activity, Wellbeing and Public Health Research Group at Sheffield Hallam University. Dr. Jones contributes to several interdisciplinary research programmes centred on enabling people to live more physically active lives. Currently, Dr. Jones is working on the Move More project, a whole systems approach to physical activity where he leads on the education strand of the programme. Dr. Jones has extensive experience working with people living with severe mental ill health and designing and implementing physical activity interventions within NHS community settings. Dr. Jones has been involved in major funded projects and clinical trials, including large-scale programmes embedded within existing NHS pathways. And finally, we'll hear from Waugh, who will offer a practice and research-based perspective. Matt is a registered mental health nurse and fitness instructor who trained on psychiatric intensive care units. Matt founded Live More, a community interest company that has co-developed 7 gyms and mental health services and a physical activity programme in talking therapies. Matt undertook a Churchill Fellowship to Australia, researching community mental health programmes. So before we dive into the presentations, I'm just going to briefly go over the flow of the webinar for today. So first, each presenter will have 10 minutes to present. After we've listened to all the presenters, we will hold a 10-minute question and answer. And following the 10-minute Q&A, we will facilitate a 5 to 10-minute social networking opportunity for those who wish to stay on for this. During the social networking opportunity, we will discuss the upcoming conference in Cadiz and the social event we have planned there, and offer you the opportunity to share some information about yourselves and any interesting projects we might be working on. The webinar will have a hard finish at 4 p.m, but for those who wish to stay on and chat, some of us will be available to do so for another 15 minutes. And then just very quickly, some webinar housekeeping. So today we are using Zoom, and in the system you're all muted except for the speakers and organisers. This prevents noise and keeps us concentrated on the actual presentations. However, we would like to give you the ability to interact with us, ask questions or make comments. So the organisers will collate the questions at the end of the talk and ask the questions on behalf of the audience. So please feel free to ask questions along the way and put these questions into the chat, but remember that we will ask them only after all the presenters have finished presenting. Also note that there's a full screen mode, so if you click this icon, you'll enter that mode. And from our own experience, this is the most convenient way of enjoying the webinar. But for now, I give the floor to Professor Joseph Firth.
Great. Thanks a lot, everybody, for coming along. And thank you very much, Masha, Victoria, Bruno, and the organisers for inviting me along today. So, yeah, I'm Joe Firth. I'm Professor of Psychology here at the University of Manchester. I'm talking about our work we've been doing around exercise for improving physical and mental health outcomes in people with severe mental illness. So you can see my slides, yeah? I'm assuming that's all fine now. Yeah, great. So yeah, here we are in Manchester, where we're known across the nation, maybe across the world, for a few things. First of all, football, obviously, some of the best football teams in the world right here, some of the best music in the world are right here. And we're also, unfortunately, quite well known for health inequalities. And the subject of health inequalities in the UK, which is obviously quite a small geographical region, has been explored by a lot of research and gained a lot of press attention, always comparing what we call the North and South divide. So this is about the life expectancy gap and the difference in health between the north of England, where we are in Manchester, and the south, where, for instance, Matt is in London. And you know, there's lots of examples of this where it's been you know, featured in a lot of different headlines. What we're doing about it over time, talking about how people in northern cities die more from cancer, from other types of communicable diseases. The most recent article I could find on it was now looking at the life expectancy of babies born in the north of England is still a year less than other places in the UK. So this is looked upon as quite a stark health inequality of a year, and obviously it is a terrible thing that we see these disparities arising. So it's about a year is getting all this attention. But one of the most overlooked things in medicine and really human health in the world right now is the largest health disparity that we don't really talk about, although it did get featured in the New York Times, about how people with severe mental illness die 15 to 30 years younger than the general population, not due to suicide or accidents. That accounts for a very small percent, over 80%, maybe over 90%, due to cardiovascular and metabolic diseases, killing people with severe mental illness at, you know, much higher rates and much younger than the general population. This has been, you know, it's persisted over time. It's been something that's, I won't talk about this because we don't have much time, but basically it's getting even worse as health disparities in general become more stark across society. We see bigger spikes in the more severe mental health groups. And all this really was the basis for our Lancet Commission on protecting physical health in people with mental illness. As it's got to the point now where for severe mental illness, the most life-threatening element of any severe mental illness, like schizophrenia, psychotic disorders, bipolar disorder, is by far the physical health elements of it rather than the mental health itself. So that was the point of the Lancet Commission on this thing. And that's a separate report that's available online, and we've updated some of that recently as well. So you can look into that. But here's like the infographic just showing a few of the key issues that are kind of driving this physical health disparity and the suggested actions. So we're talking about the much higher rates of smoking. That's very obvious in that group. The actual side effects of the medications themselves, which can be effective for treating the symptoms of psychotic disorders like hallucinations and delusions, but unfortunately incur massive cardiovascular and metabolic side effects on the individual, which left unmanaged obviously result in all types of problems. And really all this, it's all underpinned by this fragmentation of physical health in mental health care, which is quite evident in the inadequate health promotion that we see in mental health care services, which contributes then to the unhealthy lifestyles that we see among people with severe mental illness as a consequence of this and the resultant cardiometabolic burden. So, and this is not due to the clinicians like not caring. Actually, the psychologists and the psychiatrists are very aware of these physical health inequalities, and they're very keen to address them, but they're just so mental health care in general, so under-resourced and so overstretched, there's very little that they can actually do. So that was really the basis for one of the first studies that we did in this area about introducing exercise in the treatment of early psychosis here in the Greater Manchester Healthcare Early Intervention Service for young people with diagnoses of severe mental illness, could be schizophrenia, could be any psychotic disorder, or maybe something else that the diagnosis is not always that important, but they're receiving treatment for severe mental illness, usually between like 16 to 25 years old. And the idea was very simple. Let's get them out of the healthcare service into the community. We connected with all the different community leisure services around Greater Manchester and took referrals from the early intervention services. And then basically, like, either in small groups, paired people up where they were happy to do so, or, you know, individual training sessions a few times a week, arranged to meet them at the local gymnasium and just really help them get in over 10 weeks, 12 weeks, got them into health and fitness training, letting them participate in a range of like aerobic and resistance training activities, and introducing them generally to that community leisure scene. Because we found here, quite fortunate, that we do have a lot of community, you know, like council funded leisure services that not only have the gyms there, but they also have the walking groups and the football groups and the different sports initiatives that they're always running. So the idea of this was a 10-week program to introduce people into that environment in their own local community, and then make them feel not only capable of doing health and fitness themselves, but also, you know, are more aware of what services are nearby. And this went really well. This went really well while I was doing it. You know, we published a paper and all that stuff. We saw significant improvements in everything that we'd want to see improvements in, really around psychiatric symptoms and mental health, better real world functioning, better cognitive performance, things like this. In people, obviously, who are already receiving psychiatric treatment, and a lot of positive effects in the qualitative research, as probably everyone here would imagine, people, you know, with psychosis feeling a lot more motivated and more able to do things in general life when we manage to engage individuals with these, you know, more kind of like less stigmatizing interventions that are happening in the community, rather than the just traditional psychiatric treatment alone. And really all of this contributing towards people feeling a sense of recovery. And since then, you know, really the idea has got an amazing amount of traction, and not just from that study, but from all the other studies happening in that area. It's now included in like the World Health Organization guidelines, and we've done our own EPA from the European Psychiatric Association guidelines and all these commissions and stuff like that around, you know, making this a central part of care. And here's like a funny little cartoon that actually kind of portrays the sad picture of how a lot of patients still feel, you know, when they're treated for physical health. Their mental health is not really spoken about, and when they're treated for mental illness, it's at even the expense of physical health at the moment. And there's still this vast gap in the way that healthcare itself is structured for actually addressing physical and mental health together. And that's not something that can be easily overcome. So this kind of takes us to what I'll talk about very quickly for the rest of the presentation around research, which was part of the commission as well, making use of digital technologies. So until we have that perfect healthcare system of physical and mental health combined, let's start looking at scalable, low-cost methods of introducing some of these physical health things into mental health care. The idea is massive investment in digital technologies for mental health. Separately to that, loads of investment in physical health and fitness in the general population, but no one's really looking at how we can use these physical health and fitness technologies and platforms in order to help people living with mental health problems. And that's what we're doing with our EFIT group. That study, this was basically, I won't talk too much about this, basically we've done a load of work, seeing what people want, you know, what young people, 400 young people with mental health conditions across the UK, seeing what they're using at the minute. Surprisingly, lots of young people with mental health conditions, much more likely to be using physical health apps than what they are mental health apps. They're actually not very popular, but physical health apps in people with mental illness are very popular, and a lot of people turn into this already. And then even more so, going to social media for advice about physical health and lifestyle things, you know, exercise, nutrition, all these type of things are very common, most common being YouTube. So in some ways this is good because obviously people are interested, it's an opportunity, but then in other ways there's a lot of garbage out there. So, you know, you got to take the good with the bad. And we've been trying to bridge this gap to actually provide evidence-based exercise interventions for people with mental illness in the online world. One of the things we've been doing is our live fitness classes. This is very easy. Just send a Zoom link to people and run live fitness classes a few times a week for people from the early intervention service, obviously with these diagnoses, to join and do as a small group. People can have the cameras on or off or whatever they want to do. And just a way to introduce people to like home fitness and some of the resources available online. Make it a chat as well, and then do a workout together, literally live stream a workout that we've chosen as a group and work through that. So we've done this as a study. again, the full paper is actually online now. It's called the real intervention. If you search for that, in schizophrenia research, just came on the last couple of weeks, so you'll be able to find that. And what we found is a big drop off straight away with people who didn't like this approach, but then those who do, good adherence to the sessions over time, which is quite encouraging, and good improvements in, again, the same type of metrics we'd want to see improving from. And now, as part of that, so just to wrap up, with the way we've kind of finished off with this is by building out our own YouTube health channel, which is providing these resources for people to do themselves. And we're going to embed this in a more online resources of basically evidence-based and co-designed workouts and fitness content that we can disseminate, and we will soon be disseminating through the youth mental health services, but as a place for someone to go, or a clinician to send somebody to say, here's some evidence-based information, you know what I mean? Live workouts, we have a whole set of different options, from yoga to boxercise and things like that. And even, you know, we even have people with lived experience of psychosis making some of those workouts for people to kind of do at home. And we're building that into a website as well. That's all just going to be free, easy to access, easy to find types of things that people want to do, with some LLM coaching as well to direct them towards that as well. But I've run out of time, so there we go. If people are interested or have other ideas or want to contribute to the channel or anything like that, please do drop me an email, because we're still in the process of building it all out and testing it all and things like that. There's my email address. And I don't want to, you know, take Matt's and Gareth's time. So thanks everybody for that. Great. Well, I don't know if it's great, but finished. There we go. Next.
Yes, great. Thank you very much, Joseph. That was great. And now I will pass it over to Dr. Gareth Jones.
Thanks very much. Thanks, Joe. That was a really interesting talk, and really sets the an outline for me and what I'm going to talk about now. Just to give I'll share my slides in a second, but just to give an overview of what I'm going to spend the next sort of 10 minutes talking about is a program called Spaces, which is an NHS physical activity intervention delivered within the community for those with severe mental illness. Sustainability of physical activity post-intervention and kind of during intervention and so on is obviously key. We're looking for long-term behaviour change, sort of lifestyle behaviour change. And so with that in mind, community-based programs and connections are likely critical components to long-term physical activity behaviour. Spaces aims to integrate and normalise physical activity in the community and to establish connections between NHS, mental health trusts and community organisations to develop the sustainable aspect. However, community providers often report various barriers to engaging those with severe mental illness. So that's really kind of what I'm going to be talking about over the next 10 minutes. And I'll just share my screen now. And then just go there. So what does SPACES stand for? So supporting physical activity through co-production for people with severe mental illness. It's an NIHR program grant for applied research funded program to develop and evaluate an intervention which supports people with severe mental illness to live a more physically active life. Joe's done a great job of covering this, so I can skip through some of these early slides a bit, but general mental health and physical activity background sort of research demonstrates low physical activity is linked with increased metabolic risk, mental health issues, and illness has or those with that have an increased risk of cardiovascular disease, and positive mental health and physical health linked with physical activity is kind of really well known. And physical activity improves self-reported mental well-being. However, this more recent research has found that domain-specific effects of that, and specifically around leisure time physical activity perhaps has the greatest benefit. As kind of Joe alluded to, those with severe mental illness typically have a 15 to 20 year age gap, perhaps more, with 70+% of that attributable to preventable physical health conditions. And they, or as I kind of mentioned before, engage in low levels of physical activity and high sedentary behaviour. And we know the link between physical activity behaviour and sedentary behaviour with physical and health conditions. So therefore, surely if we disseminate this knowledge, that's our job done, right? It's a bit of a provocative side, but I assure you that is not the case. That a lot more work is needed in the background as well. So those with swim mental illness often have unique and significant barriers beyond the kind of general population to participating in physical activity within the community and just in general. There's a lot of around stigma, medication side effects, as Joe alluded to, anxiety, fear, and also limited connections. Loneliness is quite a key player. So we've been asking ourselves within Spaces and the related programs, how to support the first steps in being physically active. How do we support those with SMI maintain physical activity behaviour once they've initiated that behaviour? How can physical activity be integrated into routine NHS care? And how to integrate physical activity into a community provider setting? And what are the barriers and enablers for the NHS and community providers to collaborate more closely and more routinely? So I just present a kind of well-known acronym within behaviour change sort of research. ISBGET, nice catchy one, stands for it seemed like a good idea at the time. And this is like an old school research sort of methodology where you have a problem, you develop an intervention or a solution, and then you research that. And then you said, okay, well, what do we learn? Whereas that's kind of not really thought of as the best methods nowadays. It's more, we identify a problem, we have this multi sort of stakeholder deep dive into both the problems and the solutions. We have, spend a lot of time understanding context mechanisms and so on. And then we co-produce solutions kind of around that together. And then we reflect, refine and redefine from there. And this is what Spaces, or the methodology sort of Spaces kind of and related programs have kind of taken on. So as I mentioned before, Spaces is co-produced physical activity intervention delivered within NHS services, but within community settings. And a key component when we designed the intervention was this connection between NHS and community providers. And then specifically relating to the title of this webinar today, we developed a program called Co-Spaces, which is essentially a much deeper dive into the community component of Spaces. And that's because we identified within the initial sort of work programs of the initial grant that this is a much more significant component than we thought, and we'd need further resource to properly give that the light of day. So Spaces, as I'll kind of skim through this. It's not necessarily as relevant for today, but has 4 main worker packages. But just to show the robustness of the program, where we co-produced an intervention, took about 18 months, so real deep dive into the problem and the solutions. We then did a feasibility acceptability trial with NHS sites across the UK. Then we're currently in a full-scale RCT and also a process evaluation. And again, just to kind of go into some of the deep dive of the development package, we spent a lot of time identifying barriers and enablers, determined the key elements of that intervention. We finalised the intervention for the feasibility and acceptability trial, and then we used that trial to further refine the intervention for our main RCT. There's loads of inputs into all of this as well. So there's postal surveys, evidence reviews, focus groups, interviews, think aloud interviews, acceptability and testing and usability testing and so on. So it really was a very comprehensive design process. And there was also PPI input throughout as well, I should add. So a very brief overview of what the intervention is. It's a group-based physical activity intervention for those with SMI delivered by the NHS within a community setting. And what the other sort of main component is kind of one-to-one behavioural support. And there's also some other tertiary kind of bits around a participant handbook, activity monitor, and so on. Just to give you some further evidence base, it's all backed by kind of theoretical design. We used linked quite heavily on COM-B model and behaviour change wheel, and then also some other psychological theories such as self-determination theory as well. Within the intervention components you see here, on the face of it might seem quite obvious, whereas actually there's over 30 behavior change techniques embedded within all of those different components. And they were selected through that 18-month process, and kind of we developed and kind of refined what's really going to help and support someone to change their behavior and to go through a process from being perhaps quite sedentary to living a more active life. And some of the key ingredients, just to kind of highlight, is around the social aspect, perhaps around the actual venue itself, the stability and integration of between NHS and community settings, and then also the consistency of the intervention itself. Some nuanced learnings was the types of physical activity interested. Those with SMI were interested in, walking, indoor activity classes, community sessions. It was, it's really quite broad. The venue of which physical activity takes place is really important. I'll talk about more of that in a second. And also the person providing, delivering the sessions. Having some form of mental health background is really key. And often that connection between, or that collaboration between the NHS professional and a community provider is really, really key as well. Some understanding motivation. You'd be surprised, but a lot of people were joining physical activity in spaces not necessarily to be more active. That wasn't a bad thing, but they really wanted to be more social, to reduce loneliness and to kind of be more integrated in the community. And also the behavioural support was kind of really key to help initiate that potential behaviour change throughout the trial. So co-spaces, very quickly, we did some interviews with community providers because we really wanted to understand the barriers, because we were facing during the feasibility trial, community providers, there was a lot of barriers to engaging those and to them actually saying, yes, we'll do taster sessions, or yes, you can come do your sessions here at the community venue. So we held some interviews with community providers and physical activity coordinators in the NHS, and we also did a national survey, and then we held some multi-stakeholder workshops to co-produce some resources which would help the NHS work more collaboratively with community providers. And I'll run you through this very quickly. I'll get to the outputs because I think they're more interesting. But we use a double diamond design approach to kind of enact a lot of our processes, where we did a 6-day stage sort of process of agree and define the question, identify the problem, prioritize the problem, identify the solutions, prioritize the solutions, and then create action plans for those solutions. And these were multi-stakeholder workshops with lived experience of SMI, community providers, and NHS professionals. So this is just some pictures where we identified the problem, then using sticky dots, we prioritized the problem in a hierarchy. We did the same with solutions, and then we did the same with action plans. And we put them on this chart, or this matrix of effort, could also be termed as that resource, because we had in co-spaces, we had quite a finite amount of resource. So we said the sweet spot for us was these things, these actionable determinants that were within this sort of area of resource that we had available to us, but also had high impact. And what two things kind of came out of that: a resource that we needed to develop, so like a booklet leaflet that would be provided to community providers, and also a video to help bring that to life, where community providers, lived experience, and NHS professionals all speak to that. And we've kind of just gone through a process of finalising that at the moment. The leaflet's ready, but the video's in its final stages. But what was really key to those community providers is this idea around creating safe activity spaces. So connecting the ask to why the community provider aims. So why might they support somebody with SMI, and how might they go about do that? Explaining what mental health is, or SMI is and is not. There was a lot of stigma and demystifying needs of those with SMI as well required. So warm, welcoming environments, understanding the symptoms and conditions, and so on, just so kind of knew how their provision might best meet those with SMI. I'll just very quickly stop sharing this, and I'll share the resource, if that's okay. And just towards the end of our my time here. So this is the Creating Welcoming and Safe Activity Spaces. You can find this if you go on our website, spacesproject.co.uk. I can share it afterwards as well if you like. But you can download this resource. It basically goes through a process of, we're in talks with people like Sport England and so on about distribution of this as well. But it's all around demystifying some of these, an understanding around SMI, what it is not, how community providers can be can get engaged with supporting those with SMI. So we walk through this sort of hypothetical person around some of their needs and what might make a community provider, what a community provider can do to make them more comfortable to be active within their provision. And then as far as the NHS is concerned, connecting with community providers, we're coming up with these 3 Ps around people, place and provision. And so understanding what are the types of community providers that might help NHS professionals and mental health trusts connect with community providers, what sort of community provider they might kind of want to kind of team up with or partner with or so on. And I'll just go back to the slide very quickly. And so in conclusion then, so those are SMI, so swimmers and swimmers, want to be active through the NHS and within community settings. However, their journey is complex. We know this. NHS and community provider connection could be key to the sustainability of lifelong physical activity behaviour for those with SMI. But how do we strategically integrate community physical activity opportunities into routine care? We think this kind of link between NHS and community providers is key. Perhaps, ICBs and so on could be really key in supporting that kind of connection. And community provider mental health awareness and understanding could also go a long way to support people with severe mental illness engage in community-led physical activity. Yeah, and that's me. Thank you very much.
Amazing. Thank you very much, Gareth. That was very insightful and very interesting work going on there. So now I'll pass it over to Matt Waugh.
Awesome. Cool. I'm just sharing my screen. Hi guys, can you see that?
Yes.
Cool.
That's
Okay,
great.
cool.
Thank you.
Cool. Yeah, so I'm Matt. I'm a mental health nurse and fitness instructor based working in the NHS in London. Just going to talk through some work that we've done over the last 10 years. Actually, I started working with adolescents in Camden in 2015, where a team of us basically set up a youth club in Camden called The Hive. Essentially how it worked was we got given a caseload of adolescents who had the option to come to our youth club. If they didn't want to do that, we could meet them outreach out in a borough, which often would be their preference. Essentially, yeah, so I'd have a caseload of adolescents and had to work out how to engage them. And quickly found out that, because I was also a qualified fitness instructor, one of the best ways that I found to engage young people was by basically essentially offering them free personal training sessions in the community, often outside at sort of outdoor gyms like that, because it basically gave them a clear reason to engage with me, because they got access to a free personal trainer, which they didn't have. They often preferred the informal environment and would often learn a lot more about them in sessions than we would necessarily in more formal environments. So we found it was a great engagement tool. And we also found alongside that actually that food was a really good engagement tool. We had a small budget, so we could meet at places in the community they wanted to meet, sometimes McDonald's, sometimes Subway. I thought, given the health focus of this, I'd put Subway as the example. But we basically found training and food were great ways to engage people. And without that sort of learning always stuck with me. And yet the Hive it started as a pilot, but it's now fully funded in Finchley Road in Camden. And I moved to do my mental health nursing training at King's College London. First placement was on a male psychiatric intensive care unit. So 12-bedded male ward, very unwell males, psychotic illnesses, often with high risk levels of violence and aggression. So we had that sort of the PQ environment. And I was quite fortunate that there was actually a small dedicated gym on the ward, which is quite unusual. Often in sort of mental health units, there might be a gym, but it's generally off the ward, which means that there are quite a lot of barriers to accessing it. Patients need to get leave to be able to sort of leave the ward to go to the gym. If they get leave, are they even going to go to the gym? Often they might need a member of staff to escort them, but is a ward going to lose a member of staff for now? So the fact that the gym was on the ward itself was very beneficial in terms of engagement. And we even saw things like, in terms of families, we would find that, families members would maybe, they'd have their son would be admitted onto the ward. They'd come for the first ward round. They'd be looking around. It's quite a scary place. 12 quite heavily medicated guys walking around, quite chaotic. Ward round inevitably a bit late because of sort of the stuff going on, and they'd often be quite unhappy that someone even in the environment might be quite anti-psychiatry or not very happy about lots of the environment. And we actually found that when we'd actually engage with the families and say, your son's been in the gym 3 times this week, that often completely change their demeanor. And sometimes they'd say, well, can he stay here longer because he's not training at home? So we found actually it was a great way of actually starting to work with families as well as the patients. It was obvious that there was a lot of potential in the spaces, but as you can see, it was pretty, it wasn't very well kitted out. Basically had a treadmill, which wasn't ideal, as you obviously using quite high doses of medication. You're basically scared that someone's going to go flying off the back of it. So at that time, I founded a small company because I was at King's College London, where they have an accelerator program where they support 20 students every year to set up companies with ideas. So this idea was obviously about implementing physical activity and mental health services, and set up the company, got onto the accelerator program, and it basically just in practice gave us $5,000 to get some good equipment for the gym, get rid of the treadmill, which we did. So we actually sort of, again, in terms of your sort of co-production, we're constantly talking to patients about what they liked, what they didn't like, seeing for ourselves, what worked, what didn't work. And after qualifying as a mental health nurse, I stayed on our ward, the PQ, for a few years, but really embedded physical activity as part of, I suppose, the daily routine. And because the gym was on the ward itself, it really allowed us it to be accessed, a lot more. So it's really, I suppose, the lesson was about maximizing that time that the patient is engaging with services and going to where they are, basically. So as the patients were on the ward, we had physical activity on the ward and sort of maximized engagement that way. And obviously taking the learning that food was good for engagement, we would often get lots of complaints about the food in the unit. So we sort of used food more as an engagement tool and got some funding once a week to get the patients to cook something better, but they preferred, would all sit outside, eat it. And I think these things contributed to improving the environment, improving people's perception of being there. And we found that these things sort of contributed, it was a massive team effort. There was lots of good stuff going on, to a significant sort of reduction in violence on the ward that was sustained for a few years. And it was the sort of the physical activity program that we developed there was recently featured in the Lancet's sort of updated commission around implementing lifestyle interventions in mental health care. So all the different sort of elements of that are sort of presented quite clearly in an infographic if you want to check that out. Essentially, the good outcomes that we achieved there allowed us to essentially replicate what we did across all 6 wards of the unit, as a combination of funding from the sort of the NHS, CNW, NHS health charity, so the charity attached to our trust, and Live More, the company, and Support England grants. We essentially managed to replicate what we did across the wards. But obviously, in terms of the focus of this is more community, what we found was successful engaging patients after they left the unit was there was a peer-led football program, essentially, affiliated with the unit, which we found really, really popular. And essentially, one of the main reasons it worked, again, building on what was said in the last talk, was it was the environment. People felt that they were in the right place around people who could sort of, relate to some of the challenges, they'd experienced. So it really was, the fact that it was a peer-led environment was really important to why it worked. And it's called Minds United. And actually, we had someone from Australia who saw what we were doing and has basically implemented something in Sydney called Minds Collective, which is, again, I think worked very well, particularly if football is so popular in the UK. It's very popular amongst a wide range of cultures, and we found it was very successful getting engagement. I visited Sydney for a fellowship where we saw, again, some similar stuff. I visited a program called KBIM in Bondi, which is an early intervention psychosis community team, where they essentially, again, made the most of the environment they had, where they turned one of their staff rooms into a gym and offered a 12-week program to young people with first episode psychosis coming through the program, and it's been very successful. They published a lot, so I'd recommend that people look up at KBIM. And as well as alongside physical activity and exercise physiologists, they've also got dietitians in their team. We've tried to implement something similar in our community mental health teams in talking therapies, where we converted a room in our health centre that wasn't being used into a gym that Sport England helped equip, and now people coming through talking therapies get offered up to 12 sessions in the gym with a really good fitness instructor alongside their talking therapies. And because it's located next to the inpatient unit, patients from the 6 wards can be introduced to the gym before they're discharged to build their confidence in the environment. So in terms of the main learnings, one, again, has been said, I think physical activity within mental health services is very relational. The role of the fitness instructor leading sessions really important. We've been fortunate that we've had about 6 or 7 the last 7 instructors we've had across the unit have all been really, really good, but they've all worked in totally different ways. I'd say the consistent themes is they're consistent, they show up, they enjoy their work, they're genuine, authentic, and they're flexible. And they're all able to actually then form mini great MDD teams that they're working with, and they create training environments where people feel comfortable. In terms of actually advice for getting started, I think really important to be resourceful at the start. Make the most of the environment. If people are coming to your health centre, that can be a great place to start. And I suppose the main thing from working with patients that we found is that physical activity can have a really important role into developing agency. And what I mean by that is confidence within people that actually they're in control of their health outcomes. I think, that there's something that they can do that's going to improve things themselves. So, that's the main sort of learnings we've had. That's that.
Great. Thank you very much, Matt. That's so interesting to hear about the power of physical activity within mental health settings. It's really, really important work that's going on. So thank you so much. And thank you to all 3 of our presenters again for very, very interesting presentations, amazing work that's going on. It's so important, and great to see this kind of work kind of continuing to progress and evolve and really gain traction, which is really, really cool. So now going to turn to the Q&A. Please feel free to just raise your hand or speak and ask a question if you'd like to, and just say who the question is directed to. I don't think I see any questions in the chat at the moment. But yes, if people would like to share any questions that they have, then please do so.
I've certainly got one to help us started. I find it always takes a minute before people are brave enough to put their question in. And this goes to both Gareth and to Matt. You both talked about efforts of making physical activity kind of part of the norm, maybe going and playing on the mechanism of, identity of, are you someone who exercises, and are you someone who has agency over their behavior and what they can do about their health? And I was wondering how explicit, how straightforward are we, or have you been in your work around this? So would you explicitly target and say, to people that we're doing this to try and help your sense of identity and your sense of agency, or do we know that that's important but go about it in a more kind of subtle way? How have you approached it, and what have you found in your community engaged, prep work? What works better?
I don't know if you want to go first, not Matt, or if I guess I could always start, if you like. But I wouldn't say we have led with that. Typically, identity is a post sort of outcome for somebody who's already kind of done something, as opposed to like a motivational pre-exercise sort of or pre-state. But one thing I would say is that the really understanding somebody's motivation to want to attend a session is really key. And or in my experience so far, it's tended to be around either the social aspect or the, people, again, in my experience, people really do understand the physical and mental health benefits of physical activity, but they just don't know how to start or don't know where to start or don't feel like they're perhaps ready. And they just kind of need that kind of nudge or support or slight guidance, direction. And that's what these programs, in my eyes, are really about. And then you can build into that that identity or that, if they kind of want to, and so on. But yeah, I wouldn't say we start with that, but it can be an outcome.
Yeah, I can sort of follow. So obviously, like, things like identity is a big sort of quite sort of abstract sort of term in terms of like practical stuff that we've seen worked really well. So I can talk about both on the PQ and in the community. So a good example for, I think, as Gareth said, a lot of people come for the social element, and a lot of people that we work with don't have huge social circles, might not be in work, might not have a lot going on. So that means actually your engagement with them can be quite important, quite significant. And so with the football team, for example, that was actually started by a former patient at our hospital who then, after he was discharged, set up this team. And one of the reasons it's been so successful is because he's got a huge amount of drive that he puts towards it, and he's been able to be really focused and persistent with it. And they've been very successful getting grants, and they kept buying kit with the grants. So, but really cool kits, Adidas, Nike. Then there'd be a home kit, away kit, third kit, and it was all quite cool, like tracksuits, long trench sort of jackets. And I remember thinking at the start, wow, do we need another kit? 2019 kit, 2020 kit. And then I realized the kit was really important because it made people feel that they're a part of the team, that they felt like, and you'd see they probably put it on there that they're semi-pro or, a bit like, for them, they probably weren't in any other teams. So it I think quickly did become a massive part of the identity because they didn't have a huge amount going on outside of that club. Suddenly they were part of a team, they had a kit, and also they had a clubhouse that they could go to, hang out. So that, I'd imagine, did quickly become a significant part of their sort of identity. It was what they were doing and what they were proud about. And if you'd see them out in the community, they're normally wearing that tracksuit or whatever. So that was probably quite a good example in terms of community, and something I'd definitely recommend. Like, it's worth like doing stuff that makes people feel cool, particularly in the NHS. They're not expecting cool, so if you give them to them, it's pretty good. So that would be, in terms of community, that would be a good example. And then in terms of PQ, so in a gym itself, we'd have a whiteboard, and even if someone was unbelievable, like, people would be very unwell when they first come in there, but whatever they would come in and do on the bike, you'd write it on the white, and you'd basically frame it as like, achievement. So that's the baseline. Even if it was like a manic person coming in and doing 2 minutes before they got distracted and went off, and then invariably you'd get an improvement, or you could frame it as that. And then I think that was pretty powerful because obviously pretty tricky time when you're in a PQ, a lot's going wrong. So actually then being reinforced that you're achieving something from the whiteboard every time you go in there, you can almost, and then you can start almost to sort of frame it, you're an athlete, that you're coming in, like, that's what you do. So I think in terms of identity, I think you can, there's things you can do in terms of engagement that can make people feel that this is a good thing they're doing, which I think works pretty well.
Yeah, those were both such insightful answers. Thank you both.
Yes, great. Thank you both for those answers. We've got one question in the Q&A. So this question is, could any of the speakers share their experience of insights on developing e-health interventions aimed at improving mental health in low and middle income countries? Not sure if Joseph, you have any experience there?
Well, I've never developed them actually for low and middle income countries. I do have some colleagues who work in those settings, but I've always just developed ours for the, mostly the people around Manchester who are taking part in our in-person interventions, kind of like an accessory to add on to there. So I don't have any experience from actually having done it, only having tried to do it with my colleague David Van Kampfort, who does lots of real work around actually exercise for community like mental health in those settings in Uganda. And yeah, just like even the setup, to be honest, is so much more difficult, I guess, unless you had a proper research infrastructure out there for doing it, data collection and administration. And then, like we'll try and make something as culturally applicable as possible, but then Davey will kind of like remind us of the realities of actually, well, this is like rural Uganda where then they've got like these kids have got jobs to do on a morning and then all this stuff to do after school, and like only the teacher has access to the internet and stuff, and it's like just like insurmountable barriers without having somebody there on the ground who's set up to do the research infrastructure side of it is probably more important than people realize, and making an intervention on paper suitable for that group, it'd be very difficult to like delivering that as a research project. But that's not to say it can't be done, because David doesn't do e-health stuff, but he does do real exercise stuff in those settings. So yeah.
Great. Thank you very much for that answer there as well. Very interesting to hear about that aspect of things, and just this type of work being done in other countries as well.
Yeah, if anyone's got any examples, please feel free to share with the group or with myself, because I'd be keen to see it being done as well.
Yeah, absolutely. We'd love to be able to see what it'd be like in other contexts and what that might look like for those countries, for sure. Okay, I'm conscious of time and wondering if after our very insightful Q&A, I'm aware that we are 5 minutes to 4, and I know that some people may need to leave at 4 p.m. So one thing I am going to do first with the social networking is I just wanted to share a bit of information about a social event that we will be hosting at the conference in Cadiz next month. So if I go back to my slides, just to say that on the evening of the 28th of May, so that's the Thursday, during the conference, we will be having a social event where we will be meeting at 6:30, and we will plan to do a little bit of a walk and tapas, which will be lovely. So it would be great to see as many people there. For those who are going to the conference, this will be our own little SIG event. So I just wanted to put that out there so that everybody could see that we have our own event on the Thursday evening of the conference. And then if anybody would like to share if they are going to the conference, that would be interesting to know. People could potentially put in the chat or feel free to speak up as well. It would be great to hear from some people. Just stop sharing my screen there.
Should we talk about the Q&A questions that haven't been answered yet? Or no, sorry, we're doing the conference thing. Yeah. So
Yes.
I just saw that you messaged me separately about the Q&A, so that wasn't being rude, dismissing your conference stuff.
No,
Yes.
no, you're all good.
Do feel free to just answer it live. And then for whoever, I think given that we've only got a couple more minutes, let's use the speaker's expertise for now to get the most out of the Q&A, and then whoever can stay past from the attendees for the little networking, we'll do that afterwards. But yeah, take it away, Joe.
Okay, great. Yeah, thank you. Yeah, I see there's two questions about barriers to implementing PA programs and what role do you see for psychologists and mental health workers to close the gap? And it's an interesting one, actually. And I would say that seeing psychologists and mental health workers as the way to close the gap is not ideal. Now, there's some ideal examples where it's worked really great, like Matt Waugh, who's on the call now, obviously, is an example of that because he's a mental health nurse and also a fitness instructor. And there's like Jackie Curtis in Australia, who's just into fitness herself and was a psychiatrist who was responsible for a lot of the K-BIM's initial traction and things like that. So it can work, but it really relies on that individual being super passionate about health and fitness and also having the energy to then implement it into their service. But really, it's more about bringing in behavioral and physical health expertise into mental health care, and that's what that's the better way to do it. If it's using gyms on wards, I think Matt will agree with this. If it's using gyms on wards or if it's delivering stuff in the community, the more that you can bring actual fitness professionals, behavioral, like maybe psychology people, but also more like actual behavioral interventionists, basically, to deliver the stuff, the better it'll be. For two reasons. Number one, usually it's a lot easier there's no upskilling. You can teach people how to work with people with mental health concerns very, very straightforward type of thing, compared to trying to make a mental health clinician an expert in health and fitness or something is very difficult, especially if they're not interested in doing that. And then number two, it's just received better on the other side. Just like you don't want your mental health advice off your personal trainer, ideally, you don't want your personal training advice off your mental health professional. You want it off somebody who has got great credibility and qualification and experience in that field. So yeah, I'd say that's my opinion on it. It's more about sending it the other way. But if there is people in the service who are keen to close the gap, then they're often the best catalyst for it. But you can't really rely on that. It's more about bringing in the external expertise. Matt?
Yeah, no, I'd agree.
Thank you.
And then there's a huge, I think one of the things that we've seen is, again, it is when you're bringing people into the team, it's the racial element, it's the right person, like, and knowing what you're looking for. It's really, really important. But also then that the ability of that person to integrate within the team, because often you'll have someone who might be really consistent, doing great work, but no one really knows what he's doing. No one really values it because they don't know. And then finding ways of like integrating people within the team is really important. And also medicine, like, and healthcare is very, very hierarchical. So if you can actually then get the consultant psychiatrists on board, or the consultants that could then get a lot of momentum and move things forward a lot quicker. You can get someone who's been doing great work for 5 years, but the consultant doesn't know who they are. You could do the work for 2 weeks. The consultant knows who they are. Suddenly the doors are open. So I think actually encouraging that real MDT, people working together, and getting people to network and tell people, "Oh, this is what we're doing," even within the team, is really important, not just to work in silos.
Yeah, thank you so much for those answers. It's really interesting, and yeah, it's really important to think about how different professions can work together within these contexts, for sure. I think maybe is that sorry, just double checking, because I am aware of the time. So there's one message here. PhD student is currently finalising a physical activity integration toolkit that is designed for mental health practitioners to help support them in integrating physical activity into their psychological practice. Hopefully this work will be published soon. We need to see more physical activity training and CBT for mental health practitioners too. Yes, that's very important. Definitely a lot more physical activity training for mental health practitioners would be hugely important in this area. And again, just helping with that multidisciplinary work going on there in those teams. So, because it is now just after 4, I am going to thank the speakers again. Thank you so much for your time. Really appreciate you taking the time to share your research, share your projects. It's really interesting, really engaging and important work. Thoroughly enjoyed your presentations. And if you need to leave, you please feel free to leave now if you do. If you have time to stay on, then please do stay on if you'd like to. But completely understand you have busy schedules. So yes, we will continue on for another 15 minutes or so for those who can stay to do a bit of social networking. I might just need to ask if those who are in charge of the IT side of things, if Bruno or Miguel are able to possibly unmute attendees, and then we can have a conversation. Yeah. Great. Thank you so much for doing that.
Well, some people I recognise here. That's great. Nice to see you, Johnny Garside.
Okay, wonderful. So I see we've got people kind of trickling into the other room of, I think, people who can unmute now, but would someone be able to actually try it and see if we can hear you all speak? That would be great. No, I see people unmuting, but I'm not hearing anything on my end. Is that happening for others as well?
Yeah, I can't hear anything either.
Yes, same. I can see people unmuting, but I can't hear anything.
Well, how about we do this? So for this networking part, we were just hoping that we get some connections going with the SIG. So let me reintroduce myself. So I'm Masha. I'm the co-chair of the Mental Health and Wellbeing SIG. And I unfortunately won't be in Cadiz in May because it is very far away from me. But yeah, I have been to the last one in New Zealand, and I'm hoping to attend again in the next one. But Victoria will be in Cadiz from the SIG, so and a few other members. So yeah, that's me. But would love to hear from some other people that may be brave enough to introduce themselves. Maybe whereabouts you're based, what research you're currently doing, that type of thing.
Nan's a postdoc in our group at the moment. Can you hear us? Can you talk so to see if we can hear you? Because it seems like, oh, okay, yeah. Miguel says everyone, from mine, it seems like everyone should be able to speak. Nan, if you can hear me, can you speak? If you hopefully you have a mic or you're somewhere where you can speak, just say hi. Or maybe message me on WhatsApp, see if we can hear. I'll message you.
Hi.
Here we go.
Can anyone hear me?
Yes.
Yes.
Great. Thanks,
Hi,
Johnny.
everyone. Good to see you all, and thank you for the amazing presentations. For some reason, my chat function wouldn't enable me to put any questions during the main presentation, so apologies for that. I'm not sure whether it was my side or the settings on your side, but yeah, really insightful presentations. Great to see you as well, Joe. And yeah, just really appreciate all the work you guys have spearheaded.
Great. And do you have much more work going off in this area at the moment, Johnny? Last time we spoke, you were starting a number of interesting initiatives around community sport and mental health.
Yeah, very much so. So I think probably last time we spoke, I was at Everton Football Club,
Yeah.
but I've not long moved over to the English Football League.
Nice.
So we are kind of working on a national scale now across, the full pyramid really, and the rollout of a number of different, health and wellbeing related programs. But my specialism, and obviously you know my passion in this space of physical activity, sport, and mental health is one that I've been tasked with leading forwards and doing our collaborative work nationally with Mind around the safe and effective practice and embedding that across our network. We had a national conference in October last year to coincide with World Mental Health Day. Got some really fantastic spotlights of practice that's happening across our network in this space. I'm looking to do likewise in May, another conference in St. George's Park to this effect. So yeah, there's loads of great work going on, but I think one thing I wanted to mention is how we can kind of bridge the gap between research and practice. And I know this isn't a new one, and I know it's not a straightforward answer, but yeah, I often find the disconnect between innovation bottom upwards and it kind of being substantiated and evidenced from a research point of view top down, and somewhere in the middle we hopefully get some osmosis and get some collaboration. But I think definitely there's work to be done in that space, and yeah, just anything from a football network perspective we can do to help bridge that gap. Yeah, we're just really open to.
Great. Yeah, well, I think you've been a great example of that, how somebody can kind of take that research and use it to fuel real world initiatives beyond just more research projects. So it's been good to see your initiatives and like what that's like really how I know Matt as well. Like Matt's getting more into the research himself now just by kind of knowing us as researchers, but from a background of finding those research stuff and then just through his own hard work and initiatives, just making it a real thing. And that's what it really relies on at the moment, which is, like you say, it's really nice to see examples of that happening, but it's such a massive inefficiency in healthcare where it basically relies on the goodwill and initiatives of people like yourselves to find research and then apply that alongside your own ideas in order to then actually start a real world thing. And there's not really like an obvious mechanism, is there, for just like research into practice, not just in our field, but right across the board. But as seems like one where it'd be ripe for that type of change. And yeah, I think the online world is a place where things can be done a bit faster and a bit easier for translation and getting to people. So I've been interested in that way. I guess communities as well and stuff like what Matt's doing with the gyms. But yeah, it'd be interesting to discuss that more around like getting more traction around an actual more formalized mechanism for driving evidence-based practice through research.
Yeah, I know NIHR are doing some quite good work in that and helping connect certainly our clubs and the communities that they serve into more research opportunities and more research aware. But yeah, there's still lots of great work that's happening maybe on a place-based level. But yeah, just really keen to see how we can embed it more broadly. But yeah, really inspiring stuff, guys. Don't want to take up too much time, but other than to say, keep up the great work.
Oh, thanks. Yeah, it'd be great to reconnect a bit more and talk about these things, to get more stuff going and stuff like that. That'd be great. I'll message on LinkedIn or something.
Yeah, sounds great. Thanks, Joe.
Thank you.
Yeah, we've already had some people saying the Q&A that they would like to connect with some of the speakers, and I think you've all had your contact information there. And if not, people can very easily look you up. So yeah, I think there's some stuff incoming in your inboxes.
Hi, can everyone hear me?
Yes.
Yep.
Hi, I'm Mike Lowen. I work at Sheffield University. I just wanted to raise a point about a lot of the things you're saying is brilliant points around individuals that have got such motivation to bring about change in these areas. But what we've been working on at Edgehill with one of our PhD students is looking at the training pathways for different psychological practitioners and trying to embed more physical activity education and training within those pathways. Because there's, for example, a standard counselling degree has no training whatsoever to do with physical activity and the benefits and kind of integrating that into their practice. So she's been doing a lot of work on that, and I think that's an untapped area at the moment, that we do a lot of work with physical activity professionals, trying to upskill them to work with mental health patients, but work with our psychological practitioners, encouraging them to learn a bit more about physical activity, the benefits, how to have a few more critical conversations around integrating physical activity into their practice, and or encouraging physical activity as part of a therapy approach that they're adopting. So as I said, hopefully that's coming out soon. But I think it's a bit of an untapped area in this space at the moment that we can definitely look at.
Yes,
Yeah,
wonderful. Thank you so
definitely.
much, Michael. Oh, sorry, go on, Victoria.
No, it's okay. On you.
Yeah, I'd definitely agree with that as well.
Yeah, Matt, what have you seen, Matt, when you've been working with the clinicians and stuff in the more severe settings, or even just the talking therapy stuff? What's there like with relation to what Michael was doing, saying then? What's kind of like their baseline with their understanding of this area, and where do you think they'd need more training and stuff? What do you think would be best?
Yeah, no, it's been interesting. And again, it sort of varies from individual to individual. So I mean, obviously, the reason why we started this work with North Kensington Talking Therapies is because their service manager was really sort of passionate about it, you know, trained a lot herself and thought, well, this makes sense to bring it in. So because we had, you know, a service manager who was passionate about it, it got brought in. But that service manager has since moved on. So that you then sort of and then I suppose the service itself is it's really big. So there's about 70 therapists working within it. And I think that was what I was talking about why there's one physical activity coordinator within the team, and then you've got an awful lot of therapists. So I'd imagine the extent to which and again the way it works is that so people come into talking therapies and they can get referred to see the physical activity coordinator. But I think the rate at which the distribution of which referrals come from different people is very variable. Some people might think it's a good idea, it should be there. Some people might think, why is there a physical activity coordinator in a team full of therapists? So I think imagine if you would speak individually to people, you'd get a wide of variations of sort of responses. And I think a broader point in the NHS is that you can, when it's not working well, you can get a lot of, I suppose, interdisciplinary sort of rivalry. People are thinking, oh, we're therapists. Why is there a PT in the team? Like, what's he good? Like, whereas I think then hopefully you get to a point if you want individuals in that role who are able to go and sort of break down those barriers, then over time people become, oh, it's a really good idea that they're in this team. But I think definitely, the onus is on that individual has to make it happen, has to sort of go out and it's not easy. Find ways of sort of I suppose, embedding himself in the team and making people think actually, there's a reason why there's a fitness instructor in the team. Because I think initially people might not necessarily be receptive to it. They might actually, because they might think, why, why have we lost the funding for a therapist? Why have we got there's hundreds of gyms in the community? Why? The counter argument, like what? So I think there is an onus on that person to sort of make it clear that it's a good idea that they're there, which is tough.
Yeah, absolutely. It does feel like at the moment the system is at a stage where it's relying on people like yourself, Matt, right, to make the change, and hopefully we can move it forward to a space where there is less of that reliance on a unique skill set and above average motivation and keenness to do a great job and impact in their place of work. Okay, I'm conscious of time here, so just before Victoria wraps us up, I would like to say thank you everyone so much for such insightful conversations. Clearly there is a lot of appetite for work in this area, for conversations, for connections. So yes, for those of you attending ISBNPA, it will be wonderful. And I do hope you get to connect both with each other and with the SIG. And if there's anyone that wants to share what other conferences they're going to, I will actually be coming home for UK SBM at the end of this month, so UK Society of Behavioural Medicine. So if anyone is going to be in Sheffield, do come and say hi and we'll connect there. And now, Victoria, if you want to close us out.
Yes, thank you, Masha. Yeah, just thank you very much again to the speakers and to Matt and Joseph and to all of you attending. Very interesting work. I could talk about this for forever because it's what I'm passionate and interested in, so I could continue this conversation, but I know we don't have the time for that. However, we'd love to continue any conversations, or people feel free to reach out. I will be at the conference in Cadiz, so anybody that's there, please do come up and introduce yourselves. I'd love to chat some more. And just thank you very much again for taking the time to be here. I think in the chat, you might be able to see that we do have a link to a survey just to give us some feedback on this session. We really appreciate that to help us going forward with future webinars. So if you do have the time, please do fill that out. And just, thank you very much again to everybody for being here. Thoroughly enjoyable, really interesting and engaging work. And I hope everybody has a very enjoyable rest of their day.
Thank you all. Bye-bye.
Thanks, bye.
Bruno, do we have a way of now kind of closing this out to panelists only, or hosts and panelists only, just for a 1-minute debrief before we will end the session as well?
I don't know if I turn off the session, I'm afraid that we'll put all the webinar off. So, Miguel, do you know anything about it?
No, I mean, that's all good.
We can remove the attendees.
Okay, well, thank you everyone attending again. It's been a pleasure having you here. Okay, everyone is gone now anyway. Excellent.
Yes.
So yeah, I see that everyone else has had to go as well, but Matt,
Yep.
hugely appreciated your
Yeah.
inputs. It's so clear that you have got the kind of hands-on experience of trying to do this work. And I think it really adds a really key perspective. So, you know, I guess sometimes if trackies, if team trackies are the key to supporting physical activity in people with mental health concerns, that is the way to do it. So yeah, just wanted to thank you again.
Yeah.
Okay, and then also a huge shout out and thank you to Bruno, Miguel, Antonio. Really appreciate your support, being available, and with the scheduling, you know, back and
Yes.
forth.
No problem.
So yeah,
Yeah.
you guys make it all possible. So appreciate that too.
I know. Thank you very much for being there. Massively appreciate the support, behind the scenes support. So thank you.
Thank you, too.
Okay, good work, team. Well,
So, nice to meet you.
yes,
Bye-bye.
likewise.
Lovely to meet you too.
Have a great afternoon and evening, Europe-based folks.
Yeah. Yeah.
Thank you. Bye-bye.